We're here today with a very special guest. Dr. Emily Landon with the University of Chicago Medicine is here with us to talk about infectious disease, one of her many expertises. But this time it's in a very special way. It's all about hand washing, and more particularly about hand wash monitoring. She's introduced electronic hand wash monitoring some years back, and we consider her one of the pioneers of doing that. And we'd be very interested, Emily, in finding out what started it, what was the driver that got you originally interested?
Well, I never really planned on being a pioneer of anything, but back when I was studying medicine and trying to understand what I wanted to do with my life, it became very important to me to figure out how to make things that happen in the hospital happen more regularly, to be happening all the time. Sort of that idea of high reliability was really important to me. And I noticed that hand hygiene was an important one that we couldn't change. You can put a checkbox in an electronic medical record. You can make a form that people have to fill out. You can put a checklist on top of every central line kit, but you can't stand next to every door and make people clean their hands. And so we needed a different plan. And at first, actually, what I did is I worked with Motorola and the Illinois Institute of Technology to try and design a system that would measure hand hygiene, because that's the first step. If you can't measure it, you can't fix it. And we started there, but that system had antennas that were like as big as my head, and that's not going to work in a patient room. So we needed to find something smaller. At that time, other vendors were starting to create systems that would measure hand hygiene. We used an individual monitoring system here and trialed it in one of our ICUs, and it was great, except it wasn't quite as reliable as we knew it would need to be. And so when we found an aggregate measuring system that really worked well, we decided we'd go with that. And that's where we are today.
That's fantastic. It's nice to see how that started, a little bit of history there as well. Now that you have data, what do you like most about having verified hand washing?
Well, I'll tell you this. When I started, I did this math and I calculated out how many times I thought we'd have hand hygiene opportunities per day. And I came up with about 60,000 for the inpatient and the outpatient area. And I told the hospital that I thought we were only capturing maybe 1,000 a year. We needed to do something better. And when we installed the system that we have now, the aggregate monitoring system, it turns out we have 100,000 a day on our inpatient beds alone. That means that when I was collecting data using these secret shoppers, even if they were amazing secret shoppers, they don't stay secret for more than about 1,000 hand hygiene opportunities measured. After that, people tend to guess who they are, and that's not very much. When you're looking at 100,000 a day, that's 40 million a year. That's a lot of opportunities. So now with all of the data we have, we measure 24/7. I can tell you which night shifts are going better than which other units' night shifts. I can tell when a code has happened on a unit and people have been running into rooms without cleaning their hands at all. We can see exactly how long it takes to recover from something like a code on a unit. We can see what happens when the rooms get too busy, when our hospital is extra full. Does that change the hand hygiene, make it better, make it worse? And we can really see even small amounts of improvement. In fact, we have some data that we're in the process of getting published right now that shows that in our ICUs, for every 1% improvement in hand hygiene compliance, we've reduced MRSA acquisition by 4%. Now, that's probably on the steep part of the curve, right? And so we don't expect that we'll be able to go up 4% for every 1% forever, right? But what we do know is that we're making a difference in outcomes, even a little improvement in hand hygiene. And other systems measuring by using observers is never sensitive enough to pick that sort of thing up. But giving feedback to our teams and letting them know that even one additional hand hygiene event per patient per day, because we have about on average 100 per room per day, is enough to make a difference for that patient and the other patients on the unit. And people feel like they can do that. They can improve by one, and then the next week they can improve by one more. And the week after that, maybe they can do two. And at some point, we get close to 90, 100%.
Well, that continuous improvement model is pretty special, and it must make the Joint Commission pretty happy, because that's their standard, which is great. Now, thinking about getting approvals for this investment, they had to have a challenge or two there. Could you tell us a little bit about that?
Yeah, in fact, you mentioned the Joint Commission. The hospital was really worried that when they put in this electronic monitoring system, it was going to show that our hand hygiene compliance wasn't very good. And they were right. That's exactly what happened. However, they were really worried the Joint Commission would come by and say, this is terrible. You guys are not in compliance. Well, the Joint Commission did come by, and they said, wow, this is great. You guys are monitoring 24/7 and working on hand hygiene on every unit, not just putting up signs and having like 100 observations a month or something. They were thrilled. They thought it was exactly the sort of thing that they were looking for hospitals to be doing to improve things. Like you said, the continuous quality improvement model. So that went really well. Getting the hospital to pay for it was another issue entirely. I think it was a combination of a long campaign by me and the other people working in infection control to help people to understand that looking at 1,000 observations a year of hand hygiene compliance is a lot like looking at the toenail of an elephant. You have no idea what animal you're actually looking at. You don't know where to put your resources. You don't know what kind of effort to put into things. You just don't know where to start or where to finish. And so when we looked at the price, we asked for a capital investment, we discussed it, and it seemed like with the return on investment, using a couple of the papers that we found that model the cost of noncompliance in hand hygiene, we were able to make a case that we could improve hand hygiene even just a little, would make a big difference to our bottom line. And so far, we've seen that. I mean, obviously, calculating the bottom line of what a healthcare-associated infection prevention intervention has actually done is difficult. But we've seen less infections, and we've seen fewer patients with MRSA. We know about that. And so we know that we are making a difference, and the hospitals continue to support the program.
That's fantastic. I admire your courage to take that big step. One of the things that we find that when you're implementing a system this large, there's organizational issues that are bound to come up. I don't know if they did in your experience or not, but perhaps you could tell us a bit about that.
Yeah, there are a ton of issues that come up. I mean, we have a union hospital. All of our nurses are unionized, and they were real concerned at first that this was going to be extra surveillance on them. But honestly, it's not more onerous than the things that we already have with checklists and checking boxes in computers and that sort of thing. And so the accountability at the individual levels not nearly as onerous as they expected it was going to be because it is an aggregate system. When you use an individual monitoring system, that can sometimes be seen differently, but we think that the benefit of having the measuring tool is much better if you use it as an opportunity for people to improve as opposed to a weapon against them in terms of their employment. And so we've never taken that approach. So organizationally, it's been pretty well tolerated. The few things that I think are really important to know if you're going to do a system like this is one, you have to make sure it's correct. None of these systems are plug and play. This is not an iPhone. You don't pull it out of the package, turn it on, and go, wow, it's so cool. You have to install it. It takes some time. You want to think about how it's installed. Are you going to have empty rooms? Can you install it in a full room? For goodness sake, you really don't want to have to do an ICRA on your own hand hygiene monitoring system because that would just be doubly bad. And then once you get it installed, you have to make sure that you assess how it works in your space. And that usually takes a lot of tweaking, moving the sensors, moving things around, figuring out how things are going to work. And that's a long process. It took months to make sure that it was as accurate as we wanted it to be and as our practitioners and providers expected it to be. And then we had to go out and explain to people what it was doing, what it was measuring, what it wasn't measuring, and how it worked. We still get feedback from people that, the dispensers are not empty or not full. That's why our hand hygiene's low. And we still get complaints that it's just we have too many visitors this weekend. That's why our rates were low this weekend. But that sort of thing requires constant education and experience and talking things over in partnership with your units in terms of helping them to really embrace it for what it is. It's a tool to help us improve. It's better data than we've ever had before. And we can use that data in order to make improvements on our unit. It's not perfect. Nothing's perfect. So we don't use it to admonish people or to call people out at this point. We really use it to help us figure out how we can make improvements.
It's a great goal, and you're doing a fine job of that. When you think about the technology and the experience from the time you went back from the Motorola trials and your current supplier and things you've tried, what would you like to see next from a technology point of view that would make it a bit better, a bit easier perhaps?
Well, I really think we need individual monitoring. Individual monitoring, depending on how we do the feedback. Individual monitoring would give us a lot of better data, like what are the nurses doing, what are the physicians doing, even as groups like that. Also, it would allow us to do different ways of feedback and say, you're doing this well compared to your peers. Or, we don't necessarily have to just keep it in a locked box in infection control and then decide who needs to be in trouble, but rather a way of helping people change their own behavior. And in order to do that, we need better systems for measuring accuracy at the dispenser and accuracy in terms of entering and exiting the room. Some of those things are coming along, and there's some really new promising systems out there that we're looking to trial, and we're in talks with a number of people about that. We think that these systems are going to be more palatable and more marketable to hospitals if they come along with things like asset tracking or tracking other moments of hand hygiene, like when you open a kit that you need for a sterile procedure or an aseptic procedure, does that trigger a hand hygiene event or a need for a hand hygiene event? And what other kinds of things can be measured using the same system? Can it be integrated into your nurse call system? Can it be integrated into your bed tracking system so that everything kind of goes together and works smoothly?
Great, that's a wonderful goal and some good advice for the technology producers out there. So when you think of the whole experience and you're one of the few, APEC reported 3% of the hospitals that have gotten involved with monitoring. Some say it's as high as 5%. So for the other 95, any last minute thoughts or advice?
Well, I think there are some really exciting things happening down there are a couple of hospitals that are doing sort of crowdsourcing of hand hygiene observations and getting many more observations than they otherwise would. And that encourages people to be more aware and involved in hand hygiene. And so that's one thing that you can do now. I would encourage people to continue to validate and to continue to make the statement to their C-suite and to their physicians and to their nursing leadership, because there are a few things in healthcare that we allow to go so unbelievably unmonitored. I mean, we track every single time patients have a bowel movement in the chart, right? Nurses have to click boxes every single time they do anything to a patient. We measure vitals every 4 hours for patients who are completely stable, and yet we don't measure hand hygiene. So maybe there are places where we can be taking, this is something that adds value. But the more we talk about it, the more hospitals come on board, the more it's going to become the norm everywhere. And I'm looking forward to seeing what we can do with even more data and more ways of doing things.
Well, fantastic. Your time is very much appreciated. Thank you so much, Dr. Emily Landon. I think our visitors will certainly agree. One special factor in making the world safer, the hospital safer, and we appreciate your efforts. Thank you.
Thank you.